Hi, good morning, everyone. Welcome to our 151st CMAAO International Weekly session. Today, we are talking about oxygen therapy. And to talk about this, we have Dr. Nishant Kumar. He's an MBBS DNB doctor and from Lady Harding Medical College and has been associated with other hospitals. Sir, over to you.
Good morning, everyone, and good evening, wherever in part of the world you are. So thank you, CMAAO, for this opportunity to talk on this exalted platform. And I'd like to thank the organizers. So now the topic that I've chosen today, I was told to choose a very generalized topic, which will interest all specialities, because anesthesiology per se is a very close and a specialized topic. So the topic which I've chosen today is oxygen therapy. Now, if you see, COVID has all taught us the importance of oxygen. There are various devices, there are many sources. So I'll be just talking in brief, talking about an overview. What is oxygen? How do we store it, how do we deliver it, and what are the various devices which we can use to give oxygen to our patients, and when to give and how much to give. Remember, oxygen is a drug, so it has to be used as such. Now, first thing is when to administer oxygen. Now, the best way to know whether a patient or a person requires oxygen is to measure it objectively. It can be done simply by putting on a pulse oximeter on the finger. And if the saturation or the SpO2 is less than 94%, that means that there is a moderate to severe disease. A healthy person would usually have an oxygen saturation of 97% upwards. So 94 to 97%, yes, that means that there is some limitation, but yes, that can still be managed and oxygen may not be necessary. But usually, with less than 94%, we do say that oxygen has to be administered, better to be administered. And anything less than 92 or 90%, you have to administer oxygen. Now, whenever there is lack of oxygen in the body, what will happen? You'll have tachypnea. You'll tend to use accessory muscles to increase the oxygen intake. There will be tachycardia. You might go into shock with pale and cold peripheries. You might have sweating, and later, because of lack of oxygen, you may have confusion, agitation, reduced level of consciousness, and finally, cyanosis, which can be central or peripheral. Peripheral we see in the nail beds, and central on the lips. Now, as you can see, these are the various sources of oxygen that we have. Usually, the large hospitals, they have a liquid oxygen tank. These can store large amounts of oxygen. It is in liquid form and it is connected to the main pipeline. Smaller hospitals, there's a gas manifold where we have oxygen cylinders lined up like this, again connected to a pipeline which supplies to the entire hospital. Then, in the wards or in small hospitals, we may have these oxygen cylinders with a flow meter attached by the bedside of the patient, which delivers oxygen. And finally, at home, ambulatory, or as we saw during COVID, when oxygen was scarce, we have oxygen concentrators, which concentrate the oxygen from the atmosphere and deliver it to the patient. Similarly, one picture which I have not added is the pressure swing absorption or the PSA plants, which usually takes which is usually there to supplement in case the oxygen cylinder fails. So again, it's a large plant or it's a large oxygen concentrator situated in the hospital, almost much like requires a space almost like a liquid oxygen plant. And what it does, it concentrates the atmospheric oxygen to near about 90 to 92%. Remember, when we are giving pure oxygen, we take it as 100%. Now, the purest form of oxygen is a liquid oxygen, which is around 98% and above purity. The cylinders give you anywhere between 95% is acceptable, Oxygen concentrators usually give 92 to 95%. A very good quality concentrator might give you at 95%. But as you increase the flow of oxygen from the oxygen concentrators, the purity decreases. And the industrial or the medical PSA plants which are there, they usually give anywhere between 92%. But again, as the demand increases, the purity decreases. So we have to have a compromise of giving either no oxygen at all or some amount of oxygen with these sources like concentrators. From the plant, the pipeline travels through the walls, and finally at the ward or in the OR, ICUs, we have these wall outlets. The pipeline pressure is 50 psi. Remember, the pressure at the manifold is 2200 psi. So that is a very high pressure that has to be reduced. And oxygen concentrator, it's just above the atmospheric pressure, roughly 14.3 psi. So this is around 50 psi, the wall units. Now, again, this has to be reduced to around 14.3 psi to be deliverable to the patient. Imagine bombarding someone with a pressure of 50 psi. That will be, dangerous. So it has to be reduced to 14.3 psi before it can be delivered. Normally, a flow meter is connected. So this is a flow meter through which we can control the amount of oxygen that we are giving, and it reduces the pressure also. All wall units have, you can see here are different wall units. The oxygen, nitrous oxide, you have vacuum, and you have medical air. And you might have other gases also. You have CO2 for the surgeons also in the OR. So the best part is that with this flow meter, this is an oxygen flow meter, it will plug in only into the oxygen piped source, not in any of the source. So these are specific, and again, there are many different types of connectors. So this unit will not plug into this oxygen source. So you'll have to have a compatible oxygen source and outlet. It is called a safety mechanism, or DEST or NEST are the short forms that we use. That is the diameter index and the plunger. Like this is the plunger type of thing. So you just a male unit and a female unit, and you have the screw-in types also. So you cannot attach oxygen to any of the other outlets, or if the pins differ, you cannot plug into the outlet. So you have to make sure that they are compatible. Only then you'll be able to use oxygen. You cannot use that 50 psi, you cannot use that 2200 psi, you have to reduce the pressure. Now, these flow meters usually give a flow liter from 1 to 15 liters per minute, which are usually sufficient for mild to moderate requirement. Now, if you see this, this is for the pipeline. This outlet is for a jumbo cylinder, which I showed in the previous. So the 2200 psi is decreased to roughly 14.3 psi, and ultimately you get a flow from here. And again, there are different types of bobbins. You have the float bobbin, you have the boat bobbin, you have the circular bobbins. Usually the upper surface of bobbin displays the flows, but then there's always look at the flow meter, because a different type of bobbin will indicate a different. Some read at the bottom, some read at the top, some read at the middle. So there will be a marking on the flow meter where your bobbin will show the actual flow. So how to administer oxygen? Now we have got the oxygen in the wards in the area that we want to have. There are various devices now which can be connected to these flow meters and other devices. So we have the simple face mask, a partial rebreathing or a non-rebreathing mask, a venturi mask, high flow nasal cannula or high flow nasal oxygenation, again made popular by COVID. Moving on to severe cases, non-invasive ventilation, that is BiPAP and CPAP machines. Finally, invasive ventilation, where we put the patient on a ventilator. Moving on to that, even if the ventilator is not effective or if the lungs are damaged, ECMO, that is extracorporeal membrane oxygenation. And finally, specifically, we have hyperbaric oxygen therapy, where we deliver oxygen with a high atmospheric pressure up to 2 to 3 atmospheres. That is for reserved for specific conditions. So the most commonly used device is this. It's a simple face mask. It connects to your flow meter. Used for mild cases, usually when SpO2 is approximately 94%, or you want to give oxygen, you use this. You can use up to 10 liters or up to 15 liters with this. Remember not to use less than 5 liters, whatever be the requirement. Why? Because there's a small reservoir. It should be tightly fitted on face and it creates a reservoir. So you're exhaling into this reservoir, the fresh gas is coming into this reservoir from which you're breathing. And if you keep the flow less than 5 liters per minute, over a period of time, there will be CO2 accumulation. And again, the amount of oxygen that the patient is going to breathe will go down. So it's a sort of a rebreathing. Normally, we breathe 21% oxygen in the air, that is 0.21. FiO2, that is fractional inspired oxygen concentration. Now, with this device, we can give only up to 0.4 or 40% oxygen can be delivered. Again, this is patient dependent. So if the patient is very tachypneic and the requirement is high, so the amount of oxygen delivered or the concentration of oxygen delivered will go down. So the maximum is 0.4% or 40% that you can deliver with simple face mask, usually reserved for mild cases. Nasal cannula, more comfortable. Why? Because you can talk, you can eat, you can do other things with your mouth. Again, used for mild cases. Some people might find it uncomfortable because it goes in, these prongs go into the nostrils. So it might cause irritation, bleeding, crusting. So these are the things. Now, with these devices, with these simple devices that I'm talking about, always administer humidified oxygen. Dry oxygen is uncomfortable. So if I can show here, this is the bottle which is filled with water and oxygen bubbles through this water and is then delivered to the patient. So please remember to use humidified oxygen. Don't use dry oxygen. Normally, you can go up to 6 liters with this maximum flow, but we usually keep it at 2 to 4 liters because 6 liter or above will be uncomfortable to the patient. Now, this can deliver a higher FiO2 than the simple face mask. You can go up to 0.45 FiO2, but mouth has to be closed. And again, it is patient dependent. So if you have a patient whose respiratory rate is very high, the FiO2 again will go down and there's no way you can measure them. So it's just depend on the flow. So if you start at 5 liters, you'll be delivering around 28% with a simple face mask. With every liter, you increase it by 2%. Similarly, for this, 2 liters, you deliver around 32%. And then for every 1 liter, you increase it by 4%. So that is how it goes with nasal cannula. Now, rebreathing mask. We have a partial rebreathing mask and non-rebreathing mask. The only difference is it's simple face mask with an oxygen reservoir bag connected with it. Now, if you can see here, you have 2 valves here. So what this does is that oxygen is collected into the oxygen reservoir bag, and during inspiration, these unidirectional valves close so that there is no air ingress from the atmosphere. What the patient breathes is the oxygen from the reservoir bag. So you can give almost up to 90% oxygen to this. And when the patient exhales, these valves open and the CO2 and the expired gases are vented out. So there is no amount of CO2 trapping or air diluting the oxygen. So that's why you're able to deliver 90%. And you have to use a fresh gas flow of 10 to 15 liters per minute. Again, this might be patient dependent. The bag should always remain inflated. The flow should be so high. A partial rebreathing mask, on the other hand, is a similar apparatus without the valves. So maximum you can give up to is 60 to 80%. You keep upwards of 8 liters per minute. Again, you keep the bag inflated. Now, what will happen is that when the patient is breathing, there will be some amount of air which will enter through these holes while the patient is breathing and dilute the oxygen which the patient is receiving. So that is why with a partial rebreathing mask, you can achieve only 60% FiO2, whereas with non-breathing rebreathing mask, you can go up to 90%. So again, till this point, all these calculations that we have seen have been experimentally calculated, and again, it will depend on the patient effort. So we don't actually know how much the oxygen the patient is receiving, the percentage of oxygen. You cannot precisely titrate it. Now, this is circumvented by a Venturi mask. It works on the Bernoulli principle. It is for mild to moderate cases. Again, you can use a flow of 5 to 15 liters. There are different types of Venturi masks. Now, the recent ones that we are using, they use 3 to 6 liters per minute. If you can see here, it delivers an FiO2 varying from 0.3 to 0.6, which you can adjust by rotating this. So there are gradations. When it is fully open, it will deliver 30%. When it is fully closed, it can deliver up to 60%. Now, with amount of the closure will decide how much external air is entrapped, and you can you have to adjust the flow of the oxygen also. So with this, you can use a titrated therapy. You can know how much oxygen the patient is receiving, and you can actually titrate the percentage of oxygen that is to be given to the patient to maintain an acceptable saturation, whatever target has been set for the patient. So that's why this is a fixed performance device. It does not depend on the patient effort, and the FiO2 delivered will not vary. It will depend on the oxygen flow and the FiO2 that you have set on the device. High flow nasal oxygenation. Now, this is used for moderate to severe cases. This is a bridge between your venturi and more higher requirement of oxygen, that is your NIV or invasive ventilation. Even it can provide up to 100% of oxygen. You can precisely regulate the amount of oxygen that you're going to give. So this is a device with a humidifier and a heater. You have an oxygen and an air blender with the controls here. So this plugs into the high pressure wall unit, and it takes air from the atmosphere. There are filters, and with this blender, it will blend the oxygen air to the desired concentration that you want to deliver to the patient. And you can deliver up to 80 liters per minute. I've written 60, now the newer models are there, which can deliver up to 80 liters per minute. So that's a very high flow oxygen. Now, the fundamental behind this is that with such high flows, it will act as, it will give some amount of PEEP, keep the airway open, keep the alveoli inflated, and it decreases the work of breathing. And because of the humidification, it prevents dryness. Again, the advantages are with the cannula, the patient can move about, patient can talk, you can self-feed, provides a PEEP of 5 to 8 centimeters of water, and you can even prune the patient. Now, with this face mask or the venturi mask, it is very difficult for the patient to lie prone. So these are the cannula which fit snugly onto the face, into the nostrils, and the patient can easily prune himself if required. Contraindications. Consciousness, if the patient is not very conscious, if the GCS is poor, please do not use it. Severe RDS, again, you do not use this. Serious instability or airway obstruction, inability to cough, the oxygen will not reach the lungs. One concern is in communicable diseases, obviously, that there will be spread of injection because there's a lot of flow and it will cause contamination of the area that you're in. So how do you use it? You attach the device to flow meter, high pressure oxygen outlet. Humidifier is filled with water. Temperature is usually set at 37 degrees centigrade. It can be set higher or lower. It has a gradation from 34 to 42 degrees centigrade, depending on the patient comfort. You start with a flow of 60 liters per minute with an FiO2 of 1, and you attach the nasal cannula to the heater tipping, connect to the patient, and you target a saturation of more than 94%. And depending on the response, depending on the patient's response, you can gradually, you first come down on the FiO2, and then you come down on the flow. Because remember, flow is thing which will cause decreased work of breathing and will be providing a bit of PEEP. So you first come down on FiO2, and then gradually you come down onto flow. Now, once the flow is around, say, 10 to 15 liters, then you can switch over to other simple device. Again, if the patient is not maintaining saturation with these devices, you go in for non-invasive ventilation. Again, for severe cases, with this, the oxygen can be supplemented. Again, this is very useful for your COPD, asthma. Again, this is a bridge between the bridge for mechanical ventilation. That means when you don't want to intubate or you don't want to tracheostomize, if the airway is patent, patient is conscious, continuously breathing, and reflexes are present, then you can use this till and avoid mechanical ventilation to a certain extent. It has to be a tight-fitting mask, and pressure on the nose bridge is one of the major complications. Many patients actually develop necrosis. So you have to have a very good padding. Normally, two modes are used, the CPAP and the BiPAP mode. CPAP is a constant flow at a pressure, much like your HFNO, and it is the same during inspiration and expiration. It improves gas exchange. You start at 10 centimeters of water with an FiO2 of 0.6, and then you upgrade it or downgrade it. With the BiPAP, you can vary the amount of pressure that is applied during inspiration and expiration. Again, it improves the work of breathing, commonly used in COPD, where PEEP is more important than the inspiratory pressure. So these are the usual settings that you keep. For COPD, you start with this therapy, and then again you increase or decrease as per need. So again, this is the first choice in severe ARDS. ICU ventilator can be used nowadays. They have this mode, or the pressure support or the spontaneous mode can actually work as a BiPAP. Prior XHS is advisable because it can cause pneumothorax, and trial not more than 1 to 2 hours. It is considered the ceiling in end-of-life care, and if situation worsens, please move on to invasive ventilation. Now, again, a word of caution. There are two types of masks available, the NIV masks are available. One has a port or perforation for expiration. Now, these masks are to be used with these home machines with a single limb circuit. Okay. And then we have the masks which do not have any expiration port or exhalation holes in them. Those are the masks to be used when you're using NIV with the ventilator. So this is very important. Why? Because if you use the mask with the exhalation valve in the two-limb circuit with the ventilator, the pressures will never be achieved because there will be a constant leak from the exhalation valve. Similarly, if you use a non-perforated mask or the mask with no holes with this machine, imagine the patient cannot exhale to the atmosphere at all. And this was one of the major causes of pneumothorax that we saw in COVID, because the mask without the expiration valve was connected to these machines, and eventually the patient developed pneumothorax because of high pressure. Now, this is these masks are very tight. As I said, patient cannot talk, and it's very uncomfortable with the tightness around the head and on the nose. So we have the helmet-based NIV. We have the almost like an astronaut. So it's a well-sealing helmet. You can give both CPAP and BiPAP. It is comfortable. You can move around. It is as effective as the mask. The only thing is that it is a bit claustrophobic, but you can talk and you can see around, and you don't have a tightness around your head. Finally, if nothing works, we have to go in for invasive ventilation, that is intubate the patient. Again, for severe ARDS, where the PaO2 FiO2 ratio is less than 200. That means that the amount of oxygen dissolved in the blood, or partial pressure of oxygen in the blood divided by the oxygen that the patient is receiving, is 200. You have to go in for invasive ventilation. Unconscious patient, saturation remains persistently low after the above methods. The hemodynamics and tachypnea are not settling. There's CO2 retention, other comorbidities, or if the patient is shocked, it is advisable that you go for invasive ventilation. In very severe cases where the lung has actually failed and there's severe infection, you have gone to the maximum settings of the ventilator, yet you cannot maintain oxygenation, then we have to go in for ECMO, that is extracorporeal membrane oxygenation. We have two types, veno-venous and veno-arterial ECMO. Here the blood is drawn from the vein, it goes through a membrane oxygenator where oxygen is supplied, and again it is delivered back into the body via either the vein or the artery. It requires heparin and protamine so that the blood doesn't clot in the circuit. And again, this is a very specialized equipment used in critical care areas. Hyperbaric oxygen therapy. Now, this is oxygen at a very high pressure in the specialized chamber, classically and commonly used for vents or decompression sickness faced by the divers. So every naval unit, every port will have this thing. But again, this is now upcoming for non-inhaled ulcers, some dermatological conditions, some carcinoma. So it's an ongoing research which is there on hyperbaric. So you give 2 atmosphere of oxygen for 95 minutes. You give 3 to 8 sessions. The basis is that the pressure of oxygen in the alveoli is increased, so the diffusion is increased. And increased by, as I said, the increased pressure surpasses the thickened alveolar membrane and improves oxygenation. Complications, as I said in the beginning, oxygen is a drug, so it is not without complications. You have oxygen toxicity. If you give too much of oxygen, it might depress ventilation. In the neonates, it might cause you have absorption atelectasis, and obviously too much of oxygen is always a fire hazard, so you have to be prepared for that. So how much oxygen is it? If you're giving 100%, you should not give it for more than 12 hours, 80%, not more than 24 hours, and 60%, not more than 36 hours. So the idea is to maintain oxygenation of the patient with minimal use of oxygen. That is why we have gone on to the graded oxygen therapy, because if we give too much, then again it can cause complications and side effects. The goal should be to use the lowest possible FiO2 compatible with adequate tissue oxygenation. That is the goal. And as Paracelsus said in 1538, all things are poison and nothing is without poison. The dosage alone makes it so a thing is not poison. Thank you.
Thank you, Dr. Nishant, for the wonderful and insight presentation about oxygen. I think a question which a lot of people were asking during the COVID time for sure.
Yeah.
And I think there will be a lot of questions. I would let Dr. Monica to take care of the session right now. I'm actually driving. So Dr. Monica, and I also see Dr. Chong is here. He's a chair for CMAAO. Just one question which I had, I know when I floated this presentation everywhere, is there any infection, like we talked about black fungus that time, associated with having an oxygen, kind of equipments which are there in the hospital and the kind of diseases which it can be transmitted. So
yeah.
Can you throw some light on that? And then,
the thing is that you have to change water. You have to disinfect your humidifiers. If the same humidifier, you have to regularly disinfect it. You should have a separate set. You cannot use the same cannula. That is why, because if you use the same cannula, again, this will cause problems. It will cause spread of infection. So yes, black fungus was a concern. It was a concern. It was because of decreased immunity, not per se because of the humidifiers, but yes, because we were very pressed at that time. So the disinfection policies maybe had taken a backseat. If you remember, we had such an inflow of patients that whatever device, wherever it was available, was given to the patient without caring for anything else. So that was one of the major reasons. But yes, routinely we don't see any such spread of infections if these devices are used properly.
Dr. Monica, can you take care of it?
Yes, I can. Thank you, Dr. Kumar. Thanks for a great presentation. What I really appreciated about your presentation was the ability to summarize a lot of the oxygen delivery devices where we see it, but we don't fully understand it. And you were able to draw the side-by-side comparisons of the FiO2, the actual indications, and kind of starting in a linear manner about how to start with the simplest device all the way to invasive ventilation. Thank you.
Thank you.
you summarized a lot of great information. And one question that I get asked, I'm an asthma specialist, is the benefit of oxygen bars. I know that this might be something that might be a very unique thing in certain areas, but people go and they go to these areas where they're sold these wellness packages of like feeling better. And in my mind, I'm thinking, why would you be exposed to oxygen beyond what you're breathing in, and you're exposing yourself to oxygen-free radicals and other damages? What are your thoughts about that?
See, the thing is, now we live in a very polluted world. Most of the cities are really polluted, and I mean, short amounts, it's just a thing. As I said, too much of oxygen will cause agitation and it gives you a kind of high. So again, it's like a drug. So many people use it a high concentration of oxygen to get a high. That is one of the toxicities of oxygen which people utilize. And again, it's all a marketing gimmick. So, I mean, they'll sell you anything.
I agree. Are there any other questions that anybody has? I think your presentation was so
Hi, good morning, Monica. Can I ask just one query? Thank you very much, Dr. Nishant. Thank you very much. Excellent presentation. In fact, I've learned a lot today about oxygen different situation. Just I was thinking all the time that during our COVID last 2 years crisis, and especially when the hospital running out of oxygen, and then somehow we use high concentration, low, then the very low. So I read somewhere in India, because of the oxygen crisis and the peak time, we couldn't give everybody same amount of oxygen. Those patients receive lower amount of oxygen, like 80% or 70, 75%. Is there any follow-up on that, and what is happen on their long-term complication or anything? You have any idea?
Unfortunately, we had a lot of COVID patients. I think the number was more than anywhere in the world, but we were so pressed. So I don't think so any of the institutes have actually have the data right now, because that at that moment, the idea was to just maintain and record. That's it. Now we have to go back to the files of the patients, extract the data, and then maybe again follow up in India is I mean, most of the studies in India, if you call the patient for follow up, they are usually unsuccessful. And now it has been a long time which has gone by. So a follow up study would really be difficult. And with I mean, the patients coming from all corners, it was not limited to one city, because there was shortage of beds. So we had in Delhi, being the center of the city, initially we had patients come in from as far as 500 kilometers. And when the beds here were full, the population of Delhi went out to cities as far as 500 kilometers for hospitalization. So again, it will be a very difficult task to have a follow-up study. It's a great idea. I mean, if we can get back to the records and follow up, we'll definitely know what are the consequences of those people who received low oxygen, and similarly those who received a higher amount of oxygen than what was actually required for them at that time.
Thank you so much.
Oxygen toxicity. I mean, that's a wonderful idea.
Thank you so much.
Nishant, can you throw some light on the home oxygen therapy? Like, post-COVID, a lot of people are still continuing doing at home without a guidance, and keep checking their oxygen, and what should be looked out in that?
See, the thing is that, as I said, many patients have had a permanent lung damage to some extent after COVID, and it's very much like your interstitial lung disease, where the lung is destroyed. And it's not that you cannot live with, you have to live with oxygen throughout. Old age, 60s, 70s, and patients with ILD, they're doing fine with a saturation of 88%. So they cannot do strenuous activity. They will get breathless with the strenuous activity or exertion. Yes, but continuing oxygen therapy just to chase numbers is not, I would not support that. I mean, if you're feeling fine, if you're able to do your daily activities, even if you have a saturation of say 90%, that is fine. You don't have to make it 100%. You don't have to chase the numbers. So now with these modern technology, what we are doing is that we always treat the numbers rather than we treat the patient. So the emphasis has to be on treating the patient rather than treating the numbers. So numbers will guide you to the treatment, but it is the patient who will tell you whether he is better or not. So yes, as I said, any of these devices, most commonly oxygen concentrators are used at home. You have oxygen concentrators which deliver up to 5 liters per minute. You have oxygen concentrators which deliver up to 15 liters per minute. Now, a good quality concentrator would deliver an oxygen concentration of 90% and above, even at 15 liters, whereas if it's not a good quality, your oxygen concentration in 15 liters might drop down to 80% also. So that's the thing. So it's again a flow and the demand dependent concentration. When they say that it delivers 90%, that is with the lowest flow, it will deliver 92%. As you keep on increasing the flow, again, a simple thing is that if I close my room, if I don't allow fresh ingress of air into my room, ultimately all the oxygen, all the air will be exhausted. So you have to have a fresh ingress of air in the room where you're using the oxygen concentrator to replenish the air so that more oxygen can be concentrated by the concentrator. So these are a few practical points. But as I said, if the patient is really sick, if the patient is really taken neck, you can use any of these devices up to BiPAP with a concentrator to provide graded oxygen therapy.
Thank you for your response. Are there any other questions that anybody else has? Dr. Kumar, is there anything else that you feel that you want to add to what you've said?
I think the response has been fabulous, and I hope I have solved the queries and answered the queries so that now we have to be careful when we are using oxygen in the wards and in the hospital, and we should conserve oxygen because it takes a toll on the environment also. All these concentrators and all, they actually do not benefit the environment per se. With the chemicals that we use, the manufacturing, even these concentrators, these are actually depleting the ozone. So manufacturing oxygen is taking a toll on the environment. So that again, that's why we have to conserve the use of oxygen and provide it only when it's necessary. Thank you.
That's a fantastic way to sum up your presentation. Thank you again, Dr. Kumar, for presenting today and to this audience. And like was mentioned earlier, this was presented live on social media, so many people will be engaged. If there's any questions, we'll follow it up and we'll pass them on to you. And thank you once again for being here today. And we'll see everybody.
Thank you.
Thank you. Goodbye.
Bye.
Bye-bye. Thank you so much.
Thank you.
Thank you.
Thank you everyone for joining in, and we will close the session now.